is, and this is commemorated every year, and of course that is it. And of course we shall give you a few updates about the arrangement later on, but just to know that every 29th of October is Bishop Hannington Day, and of course the service is on. And then in the other, of course, issues at hand, on the 31st, that is Friday this week, a day after tomorrow, the Archbishop of the Church of Uganda, together with the management of Church of Uganda Family TV, invite you for our third annual Echoto breakfast that is happening at Golf Course Hotel from 7:30 a.m. to 11 a.m. And of course this year's theme is parenting in the age of AI, or artificial intelligence. So you do not have to miss out on this very pertinent topic. And of course, in case you will not be able to make it at Golf Course Hotel, this service, the event will be broadcasted live on Church of Uganda Family TV and our subsequent social media platforms. And of course, here we are with our Wednesday edition of Issues at Hand. And today we are going health, and we are looking at something very, very pertinent. Of course, this is a silent killer, a silent threat, but very, very important for us to know about it. And of course, we are talking about pulmonary embolism. How many times have you heard about this? I believe we might even have someone who has not heard about this. But these are things that happen to us. And then someone dies and we say, Yafudech Kutuk. I think that's, yet there are issues that have been struggling with health-wise that you never know. Now, today we have Dr. Chris Opio, and of course from the Uganda Heart Institute to take us through today's discussion. Doctor, it's a pleasure having you this morning.
Thank you for inviting me. Good morning, our viewers. Dr. Opio Chris from Uganda Heart Institute.
We are delighted to have you. How is the Heart Institute?
We send greetings. We are very fine, thank you.
Okay. They used to tell us that numbers there are overwhelming, especially when it gets to heart diseases.
Yes, that is true. We offer a wide range of preventive, promotive, and the clinical cardiovascular services countrywide. Okay. So all the referrals in the country come to us. That's why we have high numbers. Yeah.
Okay, so today we are looking at pulmonary embolism, and of course this is something that very many, it's not in the immediate vocabulary of very many people, yet it is a silent threat and a silent killer. So probably if you could define for us what it is, so that we get to really understand this particular condition.
Okay. So when you hear the term pulmonary embolism, there are two words, pulmonary and embolism. Yeah. Pulmonary simply means lungs or anything related to lungs. Then embolism means a clot which has moved from elsewhere and it found its way in the lungs. In this case, most commonly, it's the lower limbs or the legs. That's where the clots usually originate from. And they move through the blood vessel and find its way to the lungs. So in simple terms, pulmonary embolism is a blood clot in the lungs. Yes.
Because someone would really ask themselves, how is a blood clot now comes into the lungs? And maybe to understand the science of how this clot moves, like you said, some of the places, from the leg maybe, and then from the leg up to the lungs. Why the lungs are not the heart?
Exactly. So for today, the clot can move anywhere. Can go to the lungs, can go to the heart, can go to the vein, to the brain, can go to the legs. So for today, we are focusing mainly on the lungs, but the clot can go anywhere else. For today, we are simply focusing on the lungs.
Yeah, because it's someone would ask, so how is that the science? But we want to look at the risk factors, or probably the causes of this particular condition.
Yes.
Yeah. Is it a condition or a disease?
It is a disease.
Okay.
Yes. So like you said, the science, just to shine more light, if you remember our primary science, how blood moves in the body.
Yes.
Usually blood without oxygen let's say from your hands, your legs, it moves through blood vessels. Then it enters the right side of your heart. Then from the right side, it's pumped to the lungs to get oxygen. Then once it has got oxygen, it comes back to the heart from the left side. Then eventually it is pumped to the rest of the body. Yes, so that is the normal science, what we know. Yes, so that is simply what is ideal. From the rest of it, without oxygen, to the right side of the heart, then from the right side of the heart to the lungs to get oxygen. Yes, that is what happens.
That is what happens.
Yeah. Now, if you talk of risk factors, there are several risk factors which can cause this condition or blood clot in the lungs. So there are high risk factors and those we consider moderate. So we'll start with the high risk factors. You have, let's start with immobility, or if you're not very active, immobility is an English word. Let's say you travel long distances, you're sitting in a plane for long hours, you're driving from Kampala to, let's say, Arua, roughly 12 hours distance, right? Yeah, so all that distance, if you're seated, there is blood not flowing well to your limbs, so you tend to form clots easily.
What about me who sits in the office from morning, I sit in my chair up to evening, and then I get into my car and drive back home?
Yes, that is a risk.
It's also
you're
immobility.
Sitting for long hours and let's say you're not standing up as frequent, you're seated most of the day, yeah, it is a risk factor for developing a clot. Yeah. So besides that, there is also pregnancy. So for pregnant mothers, there are several changes which happen in pregnancy. Because especially to prepare the mother during childbirth, blood tends to clot easily, so that during childbirth, not excessive blood is lost. While this is very important to the delivery process, it is also a risk factor for forming clots. Yeah. Then we talk about diseases like cancer. Cancer itself, it makes blood sticky and tends to form clots. And drugs we use to treat cancer, they also cause blood clots. Then we have, if you get a fracture, then you're at risk of forming blood clots. Fracture alone, when you get a fracture, you become immobile. You're not going to be walking. Then also the injury itself, the body is going to try to clot to prevent excessive bleeding, so you tend to form clots. Yes, yeah. Then surgeries, if you had a major surgery, also, because the body still adjusts to try and prevent excessive bleeding, still you tend to form clots more frequently. Yeah. Then if you've ever had a previous history of a clot, let's say in your legs, you're still at risk. Then there are some genetic factors. Some people lack certain proteins in blood which help with blood clotting, so they are also at risk of forming blood clots. Yeah. So
these are the high.
Those are some of the high risk factors.
Okay.
Yeah.
What about the moderate?
The moderate, we have, if you have certain comorbidities like high blood pressure, diabetes, smoking, overweight or obesity, then certain forms of family planning, especially the hormonal ones, let's say pills or the injectables. Yeah. In different forms, they make your blood vessels, they thicken, then they tend to form clots easily. Yeah. Then certain conditions like sickle cell, your blood is usually thick, so tend to form clots easily.
Okay.
Yeah. So those are some of the. Then smoking. Yeah. Also, smoking has a lot of toxins. It damages blood vessels. You tend to end up depositing fats. Then later the fats can rupture and you tend to form clots easily.
Okay.
Let alone high cholesterol, high blood cholesterol. Also, when it's deposited in your blood vessel, it can easily rupture and form clots.
So, Doctor, as we were talking about, I noted that a few things that would really raise questions, especially to our viewer out there. Especially, we shall look at pregnancy as one of the high risk factor, and of course, a pregnant mother would ask themselves, how does clotting come into the entire process of pregnancy to lead to this particular disease, and maybe someone would also consider what you talked about, diseases like cancer and the medication of cancer, because someone would say, I thought I get treatment, whether it is chemo or whatever, I get treatment and I think that is all. How is it now being a risk factor to this particular disease, the pulmonary embolism?
Okay, so I'll start with pregnancy.
Yes.
We are not discouraging people from getting pregnant, I must say, first of all. Yeah, but like I said, pregnancy, there are several changes which happen naturally in the body to accommodate the changes as the baby is growing or during childbirth. Later on, we know pregnant mothers tend to bleed a lot. So just a normal physiology of the body that blood, it tends to, the clotting process is activated. It makes blood clot easily to prepare the mother during that process of childbirth. So that during childbirth, they don't lose a lot of blood, which can be fatal to the mother. Yeah, so it's something which happened. It's not that all pregnant mothers.
Mothers watching us might fear to conceive, saying, I don't want to get the pulmonary embolism. So
just to shine more light, a risk factor doesn't mean that you're going to get, but just increases the likelihood of you getting. Yeah, that's why you don't find all pregnant mothers getting the clots, but some of them do get clots. Yeah, because it's a risk factor. Just increases the likelihood of you getting clots. Yeah.
Of course, there are a lot of issues associated with the clots. But before we get into that, maybe we can look at the symptoms of the pulmonary embolism, especially those that someone can easily notice. For example, as a lay person who is not a medic, probably things that I can look out and then I sense that maybe before even going for diagnosis, I might be having this particular disease.
So with the risk factors at the back of our minds, not everyone will get the clot, but if you do have the risk factors, there are things you can look out for. So depending on the severity, these blood vessels are of different sizes, I would say. So depending on which vessel is affected, also the symptoms will vary. So if it's a small vessel, you may have mild or no symptoms. If it's a big vessel affected, then you may have the exaggerated symptoms. So some of the common symptoms, because we said blood flows from the right side of the heart to your lungs, it is now if you have a blockage there, the area is not getting enough oxygen or blood, right? So you'll get breathing issues or shortness of breath. That is one of the main ones. You'll get chest pain, often described worse when you breathe in. Then some people will cough up blood. Then you may get things like fainting attacks, especially in the severe forms, because your blood pressure will be low, and dizziness. Yeah, there are some other small symptoms. Your heart tends to race. Yeah, among a few others.
Okay.
But those are the top ones. Breathing issues, chest pain, yeah, fainting attacks, yeah.
We have people who are, for example, people who try to exercise or to do some jogging, and then they get the shortness of breath. And then there are people who maybe they are trying to do something or they carried something heavy, and then when they sit down, they get shortness of breath. Is it all associated to this, or this can be brought by, I mean, there are moments anyone can really get, and then you realize they're struggling for their breath, they're even opening their mouth so that probably they get enough oxygen in. So is it really associated to this as well as a sign?
I wouldn't say necessarily, because there are so many causes of shortness of breath. That is, so we usually encourage you come to hospital. The way you describe your symptoms will make the clinician determine what is causing, or we look for the causes, because there are several causes of shortness of breath. Could be your heart is failing, could be infections in the lungs. Yes, so they may have similar presentation, but it's good to rule out other causes. Yeah.
It's actually the same thing I was going to ask about a racing heart and maybe chest pain, because the people who have who experience chest pain occasionally, and the only thing they've even known which medicines they buy when they get it, and then maybe for some time the pain ceases, and then after some time it comes back, and then for the racing heart, there are also moments when someone just has this for some time, but also dizziness. I think you also need to shed more light on the form or the way this dizziness surfaces, so that we can differentiate it from the normal dizziness where you wake up and you feel you do not have energy, you don't want to leave your bed, and then there are those days where you feel you're so down and dizzy. Yes.
Okay. So dizziness, there are still several causes of dizziness. Later, common is some people, they don't eat, or they don't eat well. You wake up, you're hungry, you'll be dizzy. But in this form, it may not be dizziness alone, it will be dizziness associated with some other symptoms. But still, like I said, you have to have the risk factors, because you want just to wake up, you're dizzy, and you're like, hey, I have a clot. So you should be someone who has the risk factors for the disease. Yeah.
And then just shedding more light on the chest pain and maybe the racing heart.
Yes,
associated to this particular disease.
So we have so many causes of chest pain. Commonest, we have things like angina, anxiety. Yeah, so like initially I'd previously said, for this specific one, when you breathe in, the pain is worse, or commonly around the ribs. Someone will describe, I feel pain around the ribs, or when I breathe in, the pain is worse. So that raises the index of suspicion. Yeah.
Okay. Yeah. Then when I come, when I've realized that I have all this, I walk into, do I immediately come to the Heart Institute, or I go to any facility they can diagnose this?
Yes, any clinician is able any clinician should be able to diagnose. Okay. Yeah, and refer appropriately. Yeah.
So when I walk in, what should I expect?
When you walk into
a facility and I describe my symptoms.
Yes. So the first thing when you walk into a hospital is they assess your vital signs. Then you're encouraged to consult. You see a clinician. You explain your symptoms. Then he narrows down to a diagnosis. Then afterwards he'll try to diagnose and confirm the diagnosis. Yeah. So you walk in, you talk to the doctor, you narrate your history. He tries to tease out the risk factors if you have. So some of the other things which may indicate, like if you have a low oxygen level, yeah, that is one of the simple things we can use. There are these small machines we put in the hand. Yes, so if you have a blockage in a vessel which takes blood to your lungs, your oxygen levels may be lower. than
the one that makes a lot of noise.
Exactly. So that shows your heart rate and your oxygen levels. Yeah.
Okay, so besides that, how else do you diagnose this particular condition?
Yeah, so besides history and exam, depending on where you are, if you're in a hard to reach area, definitely they don't have the advanced scans which you do in Kampala. So they'll usually use history and exam or the symptoms and signs to raise the index of suspicion. But if you're in, let's say, our center, we're able to do everything. You'll come in, we take the history, we do the exam, then we do your scans. You can do scan for the heart. Sometimes you're able to see the clot, or because the clot is blood is flowing from the right side to the lungs, your right side of the heart will be affected because of the blockage which is there. Then the confirmatory test usually is a CT scan of the chest. We inject some dye into a blood vessel. This dye moves through the vessels, and usually on the CT scan you're able to see if there is a blockage. You'll see some resistance or a different color from the other dye, which the blood should flow easily through the vessel.
Isn't the dye harmful to my blood?
It is. We usually tell you the side effects, like it can cause kidney injury, but usually we check the kidney test before, and still afterwards we hydrate and it is absorbed.
After the test,
we give you some fluids, you rehydrate, then the blood can be absorbed out.
So, I know this is medical, but someone would really want to understand how this, understand clearly how this works. You inject a dye, where do you inject it? On the hand or anywhere?
We use a big vein, let's say in your hand, wherever the cannula is put. Okay. We use a big cannula, it's inserted into a vein, then the dye is injected.
And then, the CT scan. So you're monitoring?
Yeah, so the CT scan just sees the movement of the dye through the blood vessel. Yeah.
So when it reaches where the clot is,
yes, you'll see it as what we call a feeding defect. Or the blood will not flow as it is free with the other vessels which are not blocked. So ideally it should be white. White means it's flowing well or it's not blocked. So if you see some black things, that means there is a problem somewhere. Blood is not flowing freely or easily. Yeah.
So that is an advanced at an advanced level. What about these moderate levels? You talked about people in hard to reach areas, but we also have people within Kampala who cannot afford a CT scan. Yet they would want this diagnosis to be done. How else is it done?
Usually the gold standard is doing a CT scan, because you're going to put on someone on drugs. We'll talk about the treatment. Because you're going to put someone on drugs for a long time, and those drugs also have side effects which we will look at. You really want to confirm the diagnosis, which we usually explain adversely to the patient. Yeah, you have to confirm and you treat for the desired period. Because I wouldn't want to put someone on drugs based on suspicion, drugs which would cause side effects. Yeah.
Well, Doctor, we are taking a short commercial break. When we return, we are going to look at now the treatment and the management. Because someone would say, okay, when such a condition maybe is diagnosed in my life, then the only thing I'm left with is death. Because we all fear such conditions. So someone will say, probably after the break, doctor will tell us whether when you are diagnosed with such a condition, the only thing you're left with is giving you palliative care as you wait for your last day or last minute or second, or there is hope that it can be treated, managed, and then you are healed. We are coming back shortly. Stick with us.
Issues at hand. issues at hand.
Welcome back from the break. Here we are looking at the pulmonary embolism, and of course before the break Dr. Chris told us a lot of things that we need to watch out, especially as risk factors. But my taking point majorly, especially for those things that we can avoid, was immobility. I mean, you walk in, you get out of the house, you get into the garage, drive your car to office, get a lift, and then you sit from 7:30 up to 6. You get into your car again, drive back. I mean, you do the same routine. You are at risk of, even as we talk about the other NCDs that come with these, including hypertension, but this is also very, very important. Now, Doctor, before the break, you took us through the diagnosis and what happens, and of course, you talked about the CT scan and all that is done. But let us now look at the management and the treatment. You've diagnosed me, you've seen the disease, and you've confirmed. And now what happens? Should I just call home and I tell them, please slash around where I told you I should be buried? Or
no, not necessarily. So this is something which is preventable and treatable.
Okay.
Preventable means the risk factors which you're able to manage. You really, like you initially said, immobility. Those are things which we can manage. Overweight. Those are things which someone can
overweight is also.
Yes, please, it is.
Okay.
Yeah. So the things which you can manage and control, you try and control. If you have high blood pressure, take your drugs well. If you have diabetes, ensure your control is well achieved. Yeah. So the treatment usually, there are patients in whom if we have a high index of suspicion, we can give preventive drugs. Let's say someone has had a major surgery. We know this person is going to be immobile or bedridden for some time. So in hospital, there are drugs, injections we use, or blood thinners we use, and we give this person to prevent forming the clot until they are able to start moving as they should. Then also we recommend movements at the quickest time possible. That's why you see the pregnant mothers, when you operate them, after a day, we are encouraging them to move despite the pain. Someone will say, hey, it pains a lot, I can't move, but we insist, no, please, you should move. That is the main reason. We don't want them to form the clots, which could be fatal. Yeah, so those are some of preventive, but once we confirm.
Before we leave the preventive, we are talking about encouraging mobility. People should walk around. You said someone should, at least if your journey is long, you should maybe, at what intervals should I make these stops and take a rest, and for how long should I rest?
It depends on your journey.
And how should my rest be? Because, for example, when you're in a bus has a stopover, and then you stand, you stretch a bit. Is that also helpful?
Yes, it does. Because the bus may have fixed routes, where we discourage they should have stopovers. At least if you're traveling, let's say from Kampala to Kasese, Kampala to Arua, that's roughly, 8-12 hours? Yeah. Yes, so if you're taking people all those hours without a stopover, so we recommend at least 4 hours. You stop, then you rest 10 minutes, then you can resume your journey. Yeah.
And to me, who is in the bus? Because this is not about the bus. It's about me, the person. So the bus has a stopover. How should I use the 10 minutes? Because for some people, they just get out of the bus, stand there, stretch a bit, and then get back and sit. Is that how I should take this rest?
Yes, stretching, as long as you're standing or moving around, that is enough. Yeah, as long as you're not seated for long. The moment you're seated, there is pooling of blood, or what we call the blood is static. it doesn't move freely as it should. So when you stand, it encourages flow as it should. Yeah.
Now, treatment.
Yes. So like I said, the treatment, we use blood thinners. But these drugs, they have side effects, which we explain to, so we don't encourage self-medication. I'm not going to mention the name of the drugs for those reasons. Someone can walk into a pharmacy and they buy the drug because they feel, I have chest pain, so I think it's a clot. We just walk in. Some people fear coming to hospitals. For that reason, someone can go to a pharmacy and they're like, hey, I need this drug, so I want my drug. But we do use blood thinners, and usually it depends on how you present to us. There's someone who will come in unstable, their blood pressure is low, they're very restless. So we think a clot is in a major vessel, it's the one causing their symptoms, they are fainting. So we use drugs, which I can say clot busters. So there are drugs we use to try and break the clot for patients who come in and they are unstable. Then someone who comes in, they're a bit stable, we still use the blood thinners, which include injections and some tablets. But these drugs, like we said, they can cause bleeding. So their levels, some of them we monitor the levels. That's why you should be given in hospital.
Bleeding in the nose, where?
Anywhere. Can cause major bleeding anywhere. So that's a side effect of the drugs, which we tell them. So whichever drug we start you on, there are some which have more bleeding risks, and some people have more bleeding risks. Not that everyone is going to bleed. So different patients have different bleeding risks. So we start you on the appropriate dose. Those whose levels we need to monitor in blood, we do monitor them.
So does this call for maybe admitting me for a week, for 2 weeks, or I just walk in, you diagnose me, you confirm, you give me drugs, I go?
If there are patients who come in, they are stable, they don't need oxygen, some of them we give them drugs and they go home. Then we just keep monitoring. Then someone will come in unstable, they need oxygen, we have to use those, the drugs I said, which break the clot. Those ones we need to keep you in hospital and monitor the bleeding, if you're going to bleed or not.
So there's something you talked about, one of the treatment, you said maybe you inject someone, and so someone would really want to understand how this injection walks through to the lungs. And occasionally people ask this question. I have pain in my leg, and then I take a painkiller, it goes to the stomach, and then what happens? How does it even circulate to now reduce the pain? So someone would also still want to understand when you inject me, what is the science there that now takes this medicine to the lungs to remove this clot?
Okay, that's a bit technical question, and it may be more medical. But usually when you inject the drugs, we call them anticoagulants, or something which prevents coagulation. So we give it, it's going to simply activate that clot. There is a clotting system, the normal clotting cascade, how blood should clot and what. So if you're forming clots, we are giving you something which stops the clot formation. So simply, in simple terms, let me say we are giving a drug which is stopping the normal process of clot formation. There is a lot of science to it which may confuse the viewers.
But at least that's at least the little that we can know. So someone knows that. So this is what happens, because someone would expect that maybe you give them maybe a nose drop that goes through. Yes. Okay. What dangers associated with, especially people self-medicating themselves with this disease? Because I might have it the first time, I see the symptoms, I come to hospital, you give me this medicine, and then I keep the pack. So the next time I have the same, I just walk into a pharmacy, I tell them I want this medicine, and because the pharmacist opens and they want clients, a client has come, they'll just give me the medicine.
So these drugs should be prescription based. So we discourage pharmacies from giving out these drugs. Usually we give the drugs and give patients appointment dates for coming back for review for those reasons, because we know what the drug does and we need to monitor. Then some of the drugs, there are certain foods will discourage people from eating because it interacts with the drug. So let's say greens. There's one of the drugs will tell you, no, you don't need to eat greens or vegetables.
Yet nutritionists tell me to
so
take
someone will go home, they are eating those drugs, eating those vegetables, yet it's interacting with the drug, so they'll be at risk of bleeding. That's why we give them short appointment dates. They come for review, then we decide on how long to prolong the treatment. Yeah.
Now let us look at the role of multidisciplinary teams in the treatment of the pulmonary embolism.
So before we go to the role of the multidisciplinary teams, we had talked of medical management.
Yes.
But there is also surgical management.
Oh.
There's a patient who will come, but they have contraindications to the drugs, or they are unable to use the drugs for let's say they are at high bleeding risk. Yeah, so those ones we usually can surgically remove the clot, or simply there is what we call a filter. We insert it in the legs to catch the clot before it goes to the lungs. Yeah, those are for patients in whom they have high bleeding risk, they are unable to use the clot, to use the drugs. Yeah.
Oh, it is that serious. Yeah. Then let us look at the role of multidisciplinary teams in the treatment of the pulmonary embolism.
Yes, so when we are looking at the risk factors, we talked about things like surgery, talked about things like cancer and its drugs. So definitely all these people have to be involved. Someone who is going to, let's say an oncologist, a doctor who treats cancer, who is going to initiate you on the drug, they love to tell the patient what the drug does before. Then surgeons, yeah, we have a high index of clots in surgical patients, or those with the fractures. So orthopedics, general surgeons, still they know that after surgery someone is at high risk of forming the clots. So that is where they come in. They have to know we have to give preventive drugs in such high risk patients. Yeah. Or we refer the patient, they are first assessed then. Yeah.
So don't you get cases like someone saying, I have come to treat me, and then you tell me this treatment that we are giving you has this and this and this and this as an after effect, or as a risk factor. Isn't it a way of scaring us away, the patients who come, because or worrying us more? Because when I come, you're giving me maybe the cancer medication, and then you tell me that there is also this that may come. Doesn't it scare me away from taking my drugs as I would, because of the fear of what will come after?
So we let's first say a pulmonary embolism is a medical emergency. So while we tell you the side effects of the drugs, someone may say no, but you have to know it is going to kill you first. So if you say side effects are, but still it is what is going to kill you first if you don't treat it. Yeah. So when the risks outweigh the benefits, yeah, you have to treat. We clearly state all these things before we tell the patient. Yeah. So if you don't treat it, literally you're waiting just for the time. Yeah. Because there is no way that clot is going to get out if you don't treat it.
Okay.
Yeah.
Can someone die of pulmonary embolism?
Yes, all the time.
And at what level?
It is the high incidences of death among patients with pulmonary embolism, especially if untreated or undiagnosed or misdiagnosed. Yes, because you have blood not flowing to your lungs or your vital organs, you'll go into shock, your heart will fail, you get several other complications. So death, let alone your lungs, that area which is not receiving blood, it tends to die off. Yeah, the same thing, if you don't eat with time, you'll also die, not so?
Yeah.
That's the same thing which is happening to your organ. The area which is not getting blood supply, it also dies off. Yeah, so that interferes with the pumping system of blood supply.
Okay. Then probably the other question is, for example, I also talk about diseases like maybe diabetes that have levels and stages, and cancer. Well, there's cancer, this stage, and then there's that stage that cannot be treated. They'll only manage the pain as you wait for your last minute. So does this also have such stages, that there is also this stage that a patient is at, and so there is not much that can be done, especially in treatment?
No, I wouldn't say that. Because we risk stratify our patients, we have low risk, we have high risk, we have intermediate risk. So whichever form you come in, if you come in with, let's say, high clot burden or unstable, like I said, there are drugs we give, let me say, clot busters. So at all forms, it is treatable. Yeah. So the severe forms, we are also aggressive with the treatment. Yeah, the less severe forms or low risk, intermediate risk, we are a bit less aggressive.
Okay.
Yeah,
so
but at all stage it is treatable.
Okay.
Whichever stage you come in, but because once it has reached there, it's already a bad thing. Because we say the clot moves from somewhere in the body and ends up in your lungs. So we usually want you to come in when it hasn't reached there. But someone can come, they have a swelling in the leg for 3 months. It is a clot which is in the leg. So they are coming to hospital after, let's say, 6 months or 3 months. They have had this swelling for long, but already it is late. It has already reached where we don't want it to reach. So already having pulmonary embolism is a bad thing. It's a complication of what? The clot which has moved from somewhere. Yes, so we would say that is now like the bad stage. Sure. If you come in and it's still in the legs, yes, there I would say you come early. Yeah.
Unfortunately, I might never know when it is still.
Yeah, you can. Because if you're having pain in your legs, swelling in your legs, but you're like, I think this is, you ignore it. Most people tend to ignore it. Yeah. You travel a long distance, you wake up, you feel leg pain, you think, I'm just tired. Yeah. So you'll ignore, yet eventually the clot is there. Every day it's warning you, you even see swelling, you're feeling pain. You go and buy painkillers. That is what people do, not someone will say, let me buy painkillers. Yet you are masking the symptoms of the clot. Yeah.
Now, is this managed at all the other facilities, or it's now only at the Uganda Heart Institute that this particular disease is treated from and managed?
It's supposed to be managed in all the other facilities. Ideally, wherever it's diagnosed, it's supposed to be managed and treated. Yeah.
So this one doesn't call for referral to the Uganda Heart Institute?
No, it does not necessarily, unless someone is not sure of what drugs to give, or they don't have the drugs to give. Yeah. So some of those drugs are quite expensive, like the ones we use to break the clot. You may find in pharmacies there are 3 million, somewhere around there. But you may find at the Heart Institute it's free of charge. So usually people are referred for such life-saving drugs. Yeah, they don't have the money for such drugs, but they can get it free from here. Yeah.
Okay. So you talked about all the other facilities. Someone who the immediate facility they have is a Health Center 2 or Health Center 3. Does all these also manage that at that level? The Health Center 2, Health Center 3, and...
So the problem with the Health Center 2s and 3s, they don't usually have, I think, clinicians. Yeah, so they may not be able to, first of all, diagnose the disease. So I wouldn't say they are able to treat it. Yeah. But in a general hospital, they have doctors. They should be able to diagnose and know which drugs to treat. So you refer when you're not sure of what drugs to give, or it's a high-risk patient. Yeah.
On average, how long should someone be on medication?
Yes, so if it is, we usually treat for about 9 months. Yeah.
9 months?
Yeah, if you have a clot in the lungs, we treat for a minimum of 9 months. That is if you've had the clot once. But if you get it more than once, we treat for life. You'll be on drugs for life. That is why we encourage people, it's somehow you get a clot once, you take your drugs religiously. Because someone may take for 1-2 weeks, they feel better and they stop. So then they get another one. So for that instance, we treat for life. You'll be on those drugs for life.
But you never get the disease again?
You can still get, depending on what
when I'm on drugs?
Yeah, it's still possible. Yeah, especially if you have diseases, let's say cancer. Yeah, you're not going to remove away the cancer if it's the one causing the clot, unless if it's advanced cancer. Yeah, and it's the one causing the clot, you're prone to keep getting them. Yeah.
Well, Doctor, as we wind up this discussion, wow, it was quite insightful, and so we know what to do and when. But give us your closing remarks and maybe advice to someone watching us this morning.
Okay, so my closing remarks would be, a swelling or pain in the legs, don't take it for granted, especially people who tend to move a lot, you travel long distances. You should suspect that you're at risk of forming a clot. Even pregnant mothers, you should ambulate or walk enough with it. So we encourage physical activity. Don't be seated for 10 hours on your computer because of those risks. Then people who tend to cross their legs also, we discourage crossing the legs. People who smoke.
It's a common trend these days.
Yeah, it is, but we discourage it because it will cause pooling of blood. Then, so encourage exercise, avoid crossing legs. If you try to elevate your legs more, like at home, you can use a pillow. When you put it, you elevate your legs for maybe 20 minutes. Yeah. Then avoid smoking. Those who smoke, we discourage smoking. Yeah. So it is a disease which is preventable and treatable. So you shouldn't say, I'm going to die, I've got a clot. You come to hospital, we'll treat appropriately. Okay. Thank you.
Thank you so much, Doctor. We really appreciate you for this time and the knowledge you've shared with us. Let us take caution. Let us be vigilant because, who wants to be on drugs the whole of their life simply because of something that you would have prevented yourself from? Well, that is it from today's Issues at Hand. Edrine Mukalazi is my name, and of course, just remind you that on the 31st of October, that is Friday, a day after tomorrow, Church of Uganda Family TV and the Archbishop of the Church of Uganda invite you for the annual Choto breakfast, which will happen from 7:30 to 11 a.m. under the theme Parenting in the Age of AI. And of course, it will be live on TV and on our subsequent social media platforms. Therefore, you do not have to miss out. But other than that, we wish you a blessed day from the entire team, Esther, Liz, and Patience, plus all the team that we've worked with. Goodbye.
Thank you.
Issues at hand. This is Church of Uganda Family TV.